We're ready to go. All right, thank you, Dr. Beal. So today we'll be talking about vertebral augmentation and some ways to improve the cement field and improve the outcome of vertebral augmentation. So we'll be reviewing 3 different medical devices. 2 that are classified as second-generation augmentation techniques and 1 of third generation. So we'll be reviewing together the access for the Blazer, for the Kyphoflex, and the Spine Jack. So each of them have their advantages for different vertebral body. We'll be starting with the Kyphoflex, which is a articulated unipedicular balloon that you position within the vertebral body to obtain a better fill and create a more uniformous cavity. So we'll be starting with this one. So picture here. All right. And picture here. So we'll be starting probably at L4. Picture. Picture here. All right. Just do a little skin nip here. All right. Picture again. All right, so all 3 techniques are transpedicular approaches. Picture again. And picture here, you can cone a little bit. Yeah. A little tap here, picture. Picture. Okay, so we can go lateral. We'll take a look if we have passed the posterior wall of the vertebral body. Obviously, what we're looking at right now, making sure that we're not breaching the medial wall for a classic transpedicular approach. So we should be in a good position here. For those type of techniques that, just like the Kyphoflex, that we will be positioning a steerable articulated osteotome and then a balloon. We want to make sure that we're not too perfectly in the center of the vertebral body, so we want to be a little bit on the lateral side, so we have a very nice cavity creation with the balloon that will be inflated. So if we can just go toward the features recenter a little bit, the intro cannula here. So that looks like a very good approach. So what we'll do, we'll just make some minor correction here. So about midway within the vertebral body, you can go back AP just to show a little bit the positioning. During that time, we can, so we'll be working with the Medtronic X-Speed cement. So it's a very viscous bone cement that they are already preparing. During that time, I'll be taking the power curve that is a articulated osteotome that, if you can see here, by rotating the handle, you have a steerable tip that allows you to very aggressively have a direction within the vertebral body. So breaking down the trabecular bone and going exactly where you want to go. So this is what we'll be utilizing for this procedure to create first a channel where we're going to put also a articulated balloon. So if you can just raise a little bit the flat panel here. All right. And sometimes even in neutral position, you're going to have a little bit of a curve within the the tip of the articulated introducer. So sometimes you may want to straighten this introducer by going counterclockwise slightly. So this is what we just did. There is also a point to, two other additional points just to discuss. Your cannula will arrive flush with the first laser line. So you have 5 lines that indicates that incrementally you'll be able to advance with the mallet the power curve and while cranking further the osteotome. And you have here at the base of the blue handle, you have the direction of the osteotome. So we'll be introducing everything properly. If you can just raise a little bit more the flat panel here. Yep, just raise it a little bit more. Yep, or you can go in lateral already if you want. Yep. So that should arrive flush at the first laser line. We have the direction arrow that goes exactly where we want to go. So picture here. Okay, and picture again. So you want to bring it out just slightly. Perfect. Picture again. Yeah, and now you can start to. So normally you want to do 90 degrees increments as just right before you tap. So a little tap, tap, until the next line. Picture again. And same thing here. Continue to advance. Picture again. Until the next line. Another 90 degree here. And as you can see on the lateral view, this is a very aggressive steerable curve. So it allows you really to almost be perpendicular to your site of entry. Picture again. Perfect. So now you should be completely articulated. So if you go back AP. During that time, we'll grab the balloon here. Perfect. So in that case, we could advance it even a little bit more. Okay, just raise up. So you can cross over the midline. Picture here. Perfect. And that looks pretty good. All right, so where you want to, so now we have this cavity that is created, that's this channel that is already created. What we'll do the opposite step, so 90 degrees, pull back a little bit, 90 degrees, pull back, 90 degrees, pull back, until we can completely get the osteotome out. And then there is a normally a sheet that is covering the balloon that, in comparison to a lot of other medical device, we just throw out those sheets. This one we want to keep it because we can reuse this balloon for other levels, which is an important point. This is a balloon that has a low compliance and high pressure, so it can go up to 700 psi. Due to the low compliance, we can reuse it at multiple levels, which is a great asset to have if we want to do kyphoplasty at multiple levels. So we'll just put it back. Again, we have a marker right in the mid portion of the balloon that will allow us to know when we'll be at the tip of the cannula. And we should be, if you go lateral here, perfect. All right. So just like the articulated osteotome, this is also a steerable balloon. So you advance it a little bit, and there's a butterfly handle also that will allow you to steer in the right direction. So you already see one of the markers that is out. So you can advance a little bit and then turn at the same time. Picture again. Picture. Okay, and picture here. I'll just retry, I think. Picture here. Picture. Picture. Perfect. So you see right now we're within the channel that we created. So this is a, by the way, 20 millimeter balloon. So you have different type of balloon. We're treating a L3 vertebral body, so we could have used a larger balloon, but it goes in increments between 15, 20, and 25. So probably 25 would have been great to use in that case. If we go back AP just to show where the balloon markers are located. And some of the viewers may or may not see, but this is actually, there was a memory on the C-arm here that, or there was. So while we position this, let me just talk a little bit about this C-arm. So it's a C-arm by Philips that was gracefully brought for the occasion today. These are Zenesium 90, great C-arm to use clinically. I've worked with those actually for the last couple of months. So they come only in flat panel, so great image quality. It significantly decreased the dose also of radiation, and the image quality is actually quite impressive. So they come in larger footprints, so either 21 centimeter flat panel or 30 centimeter. This is the largest one, and we are back where we want it to be. So perfect. All right. So well positioned here. Could be a little bit more midline where we could have used a larger balloon if we had it, but it's a great first location. And we can go back lateral. We'll start to inflate. Yeah, picture. Picture. So in the lateral, you want to make sure that the both markers are out, obviously, of the intro channel, the intro cannula, which it is a case. Picture again. Picture. 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 Perfect. So normally you can set a little bit the balloon here to create the cavity, and then we should be ready for the cement right now. So we'll get and picture again. Perfect. So, and prior to bringing back the balloon, you de-articulate the balloon again. And picture. And it's slowly coming back. Perfect. There may still be a little bit. There we go. Perfect, and it should be ready to inject the cement. Thank you. So this is the Medtronic CDS cement delivery system. So we'll go take another shot here. Picture here. Can go up to the cavity. Perfect. So we'll start to inject slowly. So we're raising the pressure within the system. Picture. It should be filling very nicely the cavity that we're creating. Picture. So this is a very viscous bone cement, so high viscosity, so great for fracture cleft. Picture again. Picture. And we're able to fill completely the cavity. All right. Picture here. All right. Obviously, we would continue to inject and fill completely the bone cement, but for sake of time, we'll be stopping here and passing through the next medical device. Picture. Yeah, perfect. So there is also a release mechanism to decrease the pressure. So this is something also that you can use when you feel that there's too much of a buildup of pressure within the medical device. So what we can do. Perfect. And then if I have just a stylet, should be this one. And we'll give you just perfect. All right, so let's go back AP. So we'll go, next medical device that we want to take a look is spine jack. So spine jack has been on the US market since 2018. FDA approval, but we have actually multiple more years of experience with it. It started in the EU in the 2010, so we have now 15 years of data already. So great to restore vertebral body height, great to decrease the adjacent level fracture, and great to decrease the pain also related to fracture. But more importantly, by correcting the kyphosis by reaugmenting a little bit more the vertebral body and decreasing the kyphotic angle, we're able to decrease also some of the load that we have on the facet joint. So really, over time, it seems to be great to better improve the sagittal balance and decrease also the facetogenic pain that we see in patients, and it also prevents earlier and younger patients to develop facetogenic pain. So what we'll do, we'll just angulate just a little bit more toward you as our AP Just a touch, yeah. Picture. That's probably too much. Just come back. Yeah. Perfect. So we'll go at L3. Come back again. So just spinous process in the center here. It was just slightly off. Picture. Picture here. So for the spine jack, we want to be a little bit more flat than a typical balloon kyphoplasty or vertebroplasty. So we really want to arrive at this 3 o'clock, 3 o'clock and 9 o'clock position. So we really want to take advantage of the lift picture that we'll have from this medical device. Picture again. So I spent a little bit more time just making sure that we have a great entry point within the vertebral body, because it does save some time afterward. Picture. All right, so let's go lateral here. So a lot of the data that we have now for spine jack comes out of the SACOS clinical trial. Picture. And some of the points that I previously mentioned, picture, are indeed some of the findings of that study. So you can notice here that one pedicle will be slightly lower than the other one, is slightly lower than the other one, because there's some scoliosis within this patient. Picture. That looks perfect. Okay, let's go back. Yeah, great. And picture here. And picture. 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 And does not need to be so perfect at the beginning. It does save some time. However, we'll show you the reamer with the reamer picture. So at this point, we can do the exchange. Picture again. Oh, one that is not yet there. Do you have a bevel? Just a bevel tip, no. Picture. Yeah, perfect. Okay, and if you can just demonstrate a little bit more the ventral wall. So just go down a little bit with the C-arm. Yeah, perfect. Yeah, good. So again, normally I like to see them perfectly parallel, but there's a rotation within this this patient due to the rotoscoliosis. So we can put and once you're well positioned, the rest is pretty straightforward. So you removed your intro picture here. Yeah. You want to remove your introducer, and you make sure not to breach the ventral wall of the vertebral body. Normally, you can position them about 50%. This patient is the level of trabecular bone seems to be quite low. And portion of the vertebrae is still very frozen. Picture again. Okay. So when I do see that in cadaver course, we expect that it's going to be difficult with the reamer. I'm trying to get the cannula out without losing my track.
Whenever you do this, you have a real tendency to yank harder, and you do that, you'll pull your pen out. So pen and pull, windshield wiper, he has perfect technique. It's just hard bone. Anytime you put in, instead of tap, tap, you hear a tick, tick, or you hear a squeak as you turn the jamsheety, you know it's very hard bone. Dr. Clerk, many years ago, was a fellow of mine. We encountered many such things as that, so we'll see. Sometimes you just have to pull it all out and reestablish the hole. But that's pen and pull, and always use the alternating rotation.
Go back, AP.
The wiper technique when you pull that out.
Yeah, maybe we'll just do that. All right, picture again. Just find back the picture here.
There it is.
We just lost that track there.
Looks like you're right back in the same track.
Oh, yeah. And that does happen. However, normally we have a little bit less difficulty getting our the cannula out, and should be done there. Picture. And this one, picture here. Picture here. Yeah, perfect.
There you go. It's not bending, you're just pretending.
So at this point, you want to expand a little bit the incision in which you will be using the reamer. So the reamer, that is a medical device that will allow you to create a larger channel to be able to put the jack. So this is a jack 5.0. So develop about 700 Newton of force to lift the end plate.
The reason it's called,
And what we'll do, we'll just go lateral here.
the reason it's called a reamer and not a drill, although it looks like a drill, is it's fluted on the side and will cut, makes it directional. As long as you're advancing, you can change directions with the reamer.
Yeah. And now we'll advance as much as we can. Okay. I just need to see a bit more the ventral wall, so just bring everything down. Yeah.
You do want to control the distal tip of your K wire.
Picture. Yeah, and that looks good. Picture here. Can do the same thing on the other side. Just grab the other introducer. So same thing, need to expand a little bit the skin entry point. And then we'll see if we're able to.
Okay, where it's bent a little bit. So
Accommodate. This side is finicky a little bit. So what we can do, we will do, if you go back AP, just go back AP. Picture here. A little tap, tap. Yeah. Okay, let's go back lateral. Okay, you can go back lateral. Okay, and picture here. And picture.
So that reamer is pretty aggressive. It'll go right through that hard bone.
Yeah, this side is pretty frozen.
Yeah, you can tell it's hard. I just want to try to prevent your K-wire from advancing.
Yeah.
And
Picture here.
so what happens if you advance the K-wire into the IVC?
If we advance the K-wire to AVC,
I'm just
not a
talking
lot of things.
Crew in here, Olivier. So
what we'll do, we'll go back AP, just make sure that we're well positioned on each side.
So what happens if you
Before
advance
we
into the
advance a
IVC?
little bit more.
Nothing. Here's the difference. You ask, there are two categories of physicians, two specialties. One, a vascular surgeon that's doing an ALIF procedure for
Let's go back to lateral.
over here. And an IR that's putting, let's say, a big, gigantic catheter in the IVC. So you poke a hole in the IVC, what happens? Vascular surgeon, go ahead, Olivier.
Nice thing, we're just passing the posterior wall. So now we want to correct a little bit more laterally, and that's to be quite equidistant on both sides. So what we can do, picture. Yeah, I think this side is just too frozen.
That's hard.
For the purpose of time, we'll position the jack, and we'll show the rest. We prepare the cement.
Can you talk about when you would really be using this versus balloon kyphoplasty?
Picture here.
So spine jack the question is when we'd use this as compared with balloon kyphoplasty. And anytime you really want to reduce the vertebral body,
Picture
that's
again.
what you reach for. It's not even close, the ability to reduce the fracture. So for years, I was a big balloon kyphoplasty user. Now I've gone to using just vertebroplasty or spine jack.
Just recenter a little bit more. Yeah.
And whenever the fracture, I need to reduce it, I reach for the jack. And whenever it's non-compressed but fractured, as it happens, I'll just do a vertebroplasty.
Yeah, can you just go up? Can you just bring the arm a little bit more?
For hard bone, for like if you ran your car into an embankment on I-35 or I-10.
Picture.
And you get a burst fracture. These are really good.
And then bring everything down.
You can use them with hardware. You can use them as standalone. In osteoporotic bursts, these can be used as standalone. In Magrelay 3.3 fractures or AOA4 type fractures.
Picture.
And as Olivier mentioned, these things have 700, 750 newtons
Picture.
lifting force. I mean, if you put them under your shoe and lift you off the ground.
And opening up the jack is as simple as this. Very classic also appearance of the skis that will create that lift force that you have less trabecular density more ventrally within the vertebral body. So very classically, you're going to have this a kind of inverse wedge shape, really demonstrating that this is a patient that has severe osteoporosis. So very classically, you'll be able to see this angulation within the jack. We'll be injecting the cement in very shortly. Maybe we can go back AP and do the other access for the blazer.
The skis, the deformity there, you see that's plastic bowing deformity. The jack is made out of titanium alloy, so it's not firm. It's designed to do that. It's made out of titanium alloy, which is Ti6Al4V, so titanium, vanadium, and aluminum. So it's designed to do plastic bowing deformity. So it's kinder and gentler to the end plate that it pushes up against.
So we'll open up the other one, the one that would have went into the right side, because we'll be able to see the cranial lift here, and also where the cement does exit, which is in the total distal portion of the entry cannula right there. So this is where you'll be able to have a good feel while you inject the bone cement. So. Perfect. We'll go back lateral. Whenever it's time to start the injection of cement, so you turn back counterclockwise about 3-4 times, and then very easily you can retrieve everything here. And then inject the bone cement as needed. Yeah. And as you inject, often there is a buildup of pressure within the system. Picture here. Picture. Yeah.
There's a disconnect. The thread it's
Picture again.
So that's through the threaded junction. Yeah.
So the kind he's using there has a collar attachment. It attaches onto
Picture
the
here.
channel. What you saw is it dislodged the working channel as the hydraulic pressure from the cement kicked back, and so he's pushing it back down. It's a collar fit onto the spine jack.
This is something you just need to be mindful of, and you would continue to augment this side and the other side afterward. Whenever it's time to get the system out, so very easily you can just have a rotation of the introductory cannula and pull back, and then you should have the final result right there. So we'll go with the next medical device, which is the blazer. We can go back to AP.
So remember, when you disconnect this, always twist it, because cement doesn't have any resistance to shear force.
Doug, you've done a lot of work on various balloons
Here, I'll just grab
through the years, right?
Yeah.
And
So the third medical device that we want to showcase here
This is better.
is
Better
a
device.
just
curved nitinol.
Yeah, the Seikos trial was better in terms of pain reduction compared to balloon kyphoplasty, 1 in 6 months, which is saying something. So it doesn't matter to the size of the device. Maybe that has something else to do with pain.
So the next medical device is the blazer. This is also a cavity creating device that has a very thick nitinol channel that will allow us to create cavity in different direction of the vertebral body. So vertebral bodies that have heterogeneous bones, sclerosis, sometimes when you have difficulty to reach some of the fracture cleft, you can use the blazer to be able to access those different areas of the vertebral body. So it is, again, transpedicular approach. We use a 9-gauge introducer in that case. Picture here. Picture.
This is made by IZI. So this is previously a product from Benvenue. Benvenue was sold to IZI.
Picture here.
And IZI is now owned by Halma to make it more confusing for you, just to add to the level of confusion. But
Picture here.
this directional cement and cavity creation, cement delivery is very,
Picture here.
very nice. By the way, if anybody
Picture here.
here needs access to any of these products and you don't know who to
Picture here.
contact, just let me know.
Picture. We'll just go lateral. Yep. So again, for this one, you may want to put the tip of the needle perfectly in the center or a little bit more lateral if you use a, now we can make some correction here. Picture. Yeah. Okay, let's go back. Let's go back AP. So by being perfectly in the center of the vertebral body, you can use the medical device both on the right lateral portion or the left. If you're a little bit more, let's go back lateral, yeah.
Finish what I was saying about the IVC. The difference is if you have an open case and you nick the IVC, the patient dies, or you have to have a heroic save. If it's a closed case and you make a big hole in the IVC, nothing happens. Pressure difference, the retroperitoneum.
Perfect.
And if you put that
Let's
into
go back AP.
let's say you put the K-wire into the aorta, what would happen there? Nothing. Nothing. Remember, we used to do lumbar aortography with a 17-gauge serrated needle. And then after we'd squirt the contrast into the aorta, what would you do then? Just pull it out. Nothing. Tamponades itself. So don't have to get too excited about things.
So on the blazer also, there is one arrow that allows you to understand where the thick nitinol channel will be exiting. So again, want to make sure that, so right now, I'm a little bit more in the center of the vertebral body. So, okay, let's go lateral here. Yeah. Perfect. Perfect. Picture. Okay. Picture. Yeah. All right. So the arrow is located right here. So now if we are to open up the medical device, should see a nice picture. Cavity created there. All right, so let's go back AP just to showcase a little bit where this is going.
So it kind of has a built-in cure.
And we should have this cement ready. This is the IZI cement, the Versti Fix cement.
Through that same can.
This cement has aggregate of barium sulfate. So it is a little bit different than other bone cement, which you'll be able to see when we are. So this is a good example to be able to cross easily the midline on the image here. And that bone cement is a medium viscosity cement. So about 350 Pascal seconds. So as you can see here.
Yeah.
Almost sounds like the perfect cement, Dr. Clerk.
Yeah, it is. We'll go back lateral. And we'll be injecting a little bit just to show in live fluoroscopic evaluation What does that cement look like?
It kind of has a signature sign. You'll see the cement has barren particles in it, as he was saying. So this is designed to be able to see visually the flow. So you can see the barren particles like ants marching 2 by 2 down the cannula.
Picture here. Picture here. And picture. And picture. And picture. There you go. Picture here. Picture here.
This comes out of
So you can already see, for instance, this is a great example. So you see a little bit one of the lumbar vein that contains a little bit of cement. So some of those barium sulfate aggregates can very easily help you detect some of those leak. So for instance, in that condition, I could pull back, reposition more inferiorly the blazer, and inject in a different portion of the vertebral body. So whenever you have challenges like that in the classic vertebroplasty, either you use a contralateral parapedicular approach or transpedicular approach, or you can reposition, in that case, a blazer very easily. And just to note, this is coded as a cavity creation device, so a kyphoplasty. I think we will be stopping here. So to get the blazer out, you get rid of the nitinol, the curved nitinol portion, and there should be an introduction stylet somewhere. Perfect.
Well done, kind sir.
Perfect.
Questions, comments? So what is your choice of vertebral augmentation that you use, or is it done on a case-by-case basis?
It's really case-by-case basis. So we're moving away to, for the longest time, we treated compression fracture purely for pain. And now we have medical device that, yes, all will take care of the pain reduction, but also can improve significantly function and will decrease mortality. And part of that mortality data that we've seen recently was related to pulmonary infection, so pneumonia, decreased cardiac output also because patients could not breathe adequately. So height restoration is really something that we now focus more in some patients. So it depends on the patient. So if we have a thoracolumbar junction patient and a young patient after MVA, for instance, I would go with a third generation augmentation procedure, so a spine jack, for instance, to really try to restore the height as much as possible. Spine jack, I didn't mention it. It's indicated for type A fracture, so type A1, A2, A3. More and more data that comes out for the A4 compression fracture. So this is something that we'll see also in terms of utility in the future. At the end of the day, height restoration, correcting the sagittal balance, and also trying to fill as much as possible the vertebral body. So whatever, depending on your case, if you have a very heterogeneous bone, for instance, the blazer could be a good option, or using another type of kyphoplasty to be able to fill more the vertebral body. We know that pain relief decrease drastically with the amount of cement. It's the best modifier for pain relief, the variable that we have the most impact on that can decrease pain.
Fantastic. Great job. Yeoman's job with 3 devices and a C-arm to talk about. So next time, let's make this into separate sections. Great job, Dr. Clerk.
All right, thank you.